Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.
How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Dr. Lochmüller, thank you so much for joining us. I want to start by learning about your background and expertise in congenital myasthenic syndrome or syndromes. We're probably going to refer to it as CMS throughout the interview. But I want to learn about your really long and successful career and just how much expertise you're bringing specifically into this interview today.
Well, thanks so much for having me, Kira. So I'm a neurologist, and I've been working with different types of neuromuscular disorders over the years, and I started working on congenital myasthenic syndromes about 30 years ago, quite some time. And at that time, we knew that there's genetic forms of myasthenia. We call it now collectively congenital myasthenic syndromes or CMS, but we didn't know much else about it. So there were about 2 genes that were identified at the time. By now, and based on some of our research and also the research of others and progress in sequencing primarily, we know more than 35 genes that can cause CMS.
A lot has happened in the last 30 years in your career. You've helped so many people with this condition and other neuromuscular conditions, of course. I think it'd be helpful for myself and the audience to better understand the similarities and differences between the congenital form and then myasthenia gravis, and just to hear your knowledge and expertise on this.
So myasthenia gravis, or MG, is an autoimmune disorder, and that is a condition that is actually more frequent than CMS. So it's better known to the neurologists or the medical community in general, while congenital myasthenic syndromes are quite rare and often not known even to neurologists. The condition myasthenia gravis is characterized similar to CMS by symptoms of fatigable weakness, but because it's an autoimmune disease, it is characterized by specific antibodies against the acetylcholine receptor or other molecules such as MuSK that can be tested, and that's then a diagnostic test, and it's treatable with immunosuppressive agents and corticosteroids, while congenital myasthenic syndromes is, as I said, a fairly heterogeneous group of genetic conditions, so it's not autoimmune, and immunosuppressive treatments would not help at all. And different from myasthenia gravis, these conditions usually start very early in life, in the first 3 years of life. So there's rare occasions where even myasthenia gravis starts early, and there's a bit of overlap. There's myasthenia gravis in children, and in some patients with congenital myasthenic syndromes, the condition actually does not start as early as shortly after birth, but later, and some people even get only diagnosed as adults. So there's a bit of overlap, and there can be confusion about it. but generally speaking, myasthenia gravis is more an adult disorder. It's autoimmune. It's single individuals. It's not a familiar disease, while CMS is a genetic condition that usually starts in early childhood and can be treated symptomatically, but there's currently no cure or fixing the gene for it.
So, Dr. Lochmüller, in your experience, people with myasthenia gravis are often diagnosed as adults, whereas with CMS, usually people are diagnosed when they're in their childhood. But there can be overlap there. It can be the opposite, just in your clinical experience. That's what you've seen. And in terms of, moving forward of how we're going to develop better treatments for these conditions, I think we need a lot more research and just to understand how this works, and the genetics playing a big role in that. I think we understand some of the genetics. So would love to dive into a little bit more of that, because I have a personal interest in this. I learned that I am actually a carrier of CMS, and that is an autosomal recessive form. That's why I'm phrasing it that I'm a carrier for it. But in terms of myself and other healthcare providers to learn about this, what types of genetic information, in your opinion, should people be aware of? What type of information surrounding these conditions should healthcare providers be familiar with?
So that's very interesting, and thanks for giving your sort of perspective on it and your personal experience.
Yeah.
So the vast majority of congenital myasthenic syndromes are autosomal recessive. So it's, I would say overall, probably more than 95%. So there's very rare occasions with a couple of genes where it can be dominant, and then it's obviously more difficult, and even the dominant mutations are not always fully penetrant. So it's sometimes a bit confusing even for specialists. But let's say that the common forms are autosomal recessive, meaning that you can be carrier on one of your two copies of the gene, and that wouldn't then cause any symptoms. And only if in a child both the gene copy that's inherited from mom and the gene copy that's inherited from dad come together in a child, and that child then doesn't have that healthy protective copy of the gene, then the condition will present with symptoms and obviously cause problems. So some of my patients, especially in small families, as we look at nowadays, there's only this one child that has the condition, and then when I'm telling them based on a genetic report or on clinical reasoning, this is most likely a genetic condition, people are a bit puzzled and say, well, how could this be something genetic if nobody else in the family has it? But that's the nature of recessive conditions, that it really just presents within one generation, and there might be another sibling that has the condition as well, but usually you do not find it in the generation above, so the parents will be healthy as well as in the generation below, because obviously if people with CMS have children, then they will pass on one of their defect genes, but because the defects in these genes are very rare in the general population, it's a very low likelihood that their children will be affected. So being the only one in the family having CMS is actually the most likely scenario, unless, as I said, there's larger families with multiple children, and then there could be a sibling that is affected by CMS. And we see that as well on occasion.
Sure, especially if the first child that has the condition wasn't diagnosed right away, and they were like, well, we think it's random, and had a misdiagnosis. They may have other kids that then will have the disorder before a diagnosis mentions. And I'm glad that you bring up that in order to have CMS, you need to have the two faulty genes or two genes that are not working properly to then have that diagnosis. So to have, often the two different variants that are occurring so that you don't have a working copy of that gene. And you need it for the diagnosis of CMS as well. So in your experience, If a child is exhibiting symptoms of CMS, there's probably a lot of other conditions that are being considered at that time in terms of that differential diagnosis. What are the steps to actually get a diagnosis for CMS? I mean, as I said, genetic testing, that is obviously going to be very helpful, but people may not start with genetic testing. I mean, hopefully in the future, we're kind of moving towards that. But especially with your experience, are there muscle biopsies or other types of steps in terms of figuring out maybe what testing someone needs to get, kind of looking at that backwards perspective?
These symptoms come and go, so they not only get worse, as we see in muscular dystrophies, for instance, or in spinal muscular atrophy, which are differential diagnoses, but they also get better at times. So these fluctuations are really symptoms that the neurologist or the pediatrician should be aware of, and then start thinking about, is that actually a muscle condition, or is this a condition that affects neuromuscular transmission? So that's actually what where the defects are located in congenital myasthenic syndromes, where the nerve communicates with the muscle. If the neurologist thinks about a congenital myasthenic syndrome or myasthenia gravis, for instance, then one test is quite useful, which is an electrodiagnostic test where the nerve gets stimulated. It's called a repetitive stimulation. And with repeated stimulation of the nerve, the muscle action potential from stimulus to stimulus gets smaller, and that indicates a failure of neuromuscular transmission. And that's a pretty good sign for congenital myasthenia and myasthenia gravis in general. And then I would go straight on to genetic testing, as you say, because that's really nowadays how you secure the diagnosis. Muscle biopsies don't play a big role anymore unless another condition is suspected first. So if the doctor suspects, because of the weakness, that a child may have muscular dystrophy or another type of muscle disease, they may proceed to a muscle biopsy. And if then the pathologist returns a report saying, well, there isn't much wrong with the muscle, this is relatively normal looking muscle, then I think that's again a point where one should think about, is this actually a muscle disease? Is this muscular dystrophy? Or is there something wrong with neuromuscular transmission? And then hopefully come to the diagnosis and do the genetic testing. But I would say if congenital myasthenia is suspected to start with, then a muscle biopsy is not required. And obviously, genetic testing is just a blood sample, right? That's far less invasive than muscle biopsies and give more information. So we do not do muscle biopsies except in cases where it's unclear, or where sometimes we come across a gene that we don't fully understand yet, and where we do this for research purposes sometimes.
Yeah, and in the clinical space, it's, as you're saying, the genetic testing is just so important. And we're at a time right now where some people are ordering panels still of, okay, I want to order, let's say, a large neuromuscular panel. And I'm learning that a lot of the genes for CMS is included, like DOK7 would be included. That's a common one I'm finding out, and other related genes.
Yeah. So in the large neuromuscular panels, I think at least the more common congenital myasthenia genes are included, like DOK7, as you said, or the
DOK7, good to know, thank you.
Yeah. And even if the doctor didn't actually suspect that this is congenital myasthenia, just an unspecified muscle condition that comes with weakness, they will pick it up accidentally this way, right, and come to a diagnosis.
And I would imagine that testing for the specific variant is also important, not just what gene it's in, but to get even deeper, the specific genetic change within that gene. Does that affect anything in terms of the symptoms we experience of having that disorder, or the treatment that might differ? Why is it important to have not just the gene, but the variant?
I mean, for some genes, such as the DOX7 gene, that is a pure sort of loss of function scenario. But depending on how severe the mutation is, you can have complete loss of function or partial loss of function, and then that sort of gives a little handle on the severity and the progression of the condition. So that gives additional information. But there's other situations where, in fact, the specific mutation is essential to the mechanism how the mutation causes disease. So really, mutation matters and variant matters a lot for selection of the most appropriate treatment. And we have started to set up a database where we make not only that connection between gene and treatment, but also between variant and treatment. It's called Treatabolome, and that hopefully will help clinicians to decide to go directly from a genetic diagnosis from a gene and a variant to hopefully finding out what the most appropriate treatment is for these patients. And that does not only list variants for congenital myasthenia, but also for other genetic conditions.
Wow. We'll have to link to that in the show notes so that people can look into that if they're interested. And, you know, we've been talking a lot about just the symptoms in general, but in terms of that patient perspective, I mean, you've cared for a lot of patients with CMS. What has surprised you about just your years of, you know, getting to know people with the condition, and what may be surprising either to you or what has been surprising like for the patients that they've shared with you or the caregivers?
Yeah, so what's interesting or surprising is that first of all, patients are very grateful to receive a diagnosis and to get clarity, and that's a relief in itself, even if we don't always offer good treatments for them. And secondly, what surprises me is the resilience of patients with these neuromuscular conditions. So even if they do have a disability and they do obviously need to deal with a lot of issues and problems in their everyday life, they find ways how to work around it and cope with it and still have a positive outlook on life, and do hold on to jobs and families, etc. So it is very rewarding actually to work with these families.
Yeah, and just how you've seen how having a diagnosis just really is impactful in so many of these areas. And even just all right, we're not in the unknown anymore of having a diagnosis. We now are able to have more of this information. And the unknown is always going to be scarier, I think. Okay. Well, thank you so much, Dr. Lochmüller. This was really interesting. And, you know, as I shared at the beginning, very personally interesting to me as a carrier, just to learn about this. And
thanks so much, Kira. It was a real pleasure. And obviously, I'd like to hear from my colleagues if they have questions or want to discuss a patient. I'm always happy to get on the phone or on the email and discuss that.
I really appreciate just all of the decades that you've put into direct patient care and just how you're building this future in terms of people that have the condition and making a difference in their lives. So thank you so much for everything.
Thanks so much.
The genes of you and me, the genes of you and we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.